students, I am Dr. Jamila. I will talk today about ectopic pregnancy. Do you know what is meant by ectopic pregnancy? When the pregnancy occurs outside the uterine cavity, it can be, most of the time, 99% it is in the tube. The so-called is the tubal pregnancy. Otherwise, it sometimes can occur in the ovaries or in the cervical canal also, cervix also it can occur, or anywhere around the outside the uterine cavity. Then the most common site is being the tube, and that too is the ampulla. We all know there are 4 tube parts of the tube. One is interstitial portion, ischemic, and then ampullary portion and infundibular portion. The most common site here is the ampulla, because that is where the site where the sperm cells hide to the ovum. So that is the site where the fertilization occurs, and it's the broadest part of the fallopian tube. That's why it occurs mostly in the ampullary portion. And the rest of the portions is not that common, rare being the cervical canal. These are some of the sites which for the ectopic pregnancy. The etiology being, mostly we divide it in congenital, inflammatory, traumatic or miscellaneous causes, or it can be hormonal also. First being the anatomical causes, wherein the tube is too long. So that fertilized ovum has to travel for a long distance to reach the uterus. So it takes a longer time. That's why, because of there are a lot of ampullary, in the ampullary portion, because there are a lot of diverticulae, and because of accessory osteas, it gets buried, it gets lost itself. That's how it develops in the ampullary portion. And sometimes because of the inflammation, that's the most, I said congenital, the second cause is inflammation. Inflammation because of the sexually transmitted diseases, or it can be non-specific salpingitis, which can cause to ectopic pregnancy. Tuberculosis is also common in the tropical countries, in the underdeveloped countries. So these are some of the inflammatory causes. Sometimes even the benign tumors from outside the sometimes the fibroid or the ovarian tumor compressing upon the fallopian tube, which can distort that fallopian tube. As said, there is a compression, there is a narrowing. Because of that, we can get ectopic pregnancy. And apart from congenital inflammatory traumatic causes, a patient who had a previous ectopic pregnancy is always a prone candidate for again to get an ectopic pregnancy. That is how it is. The more the time she gets ectopic, repeat ectopic is more common in an ectopic pregnancy. And also patient who had a tuboplasty for infertility, damaged tube, who undergoes surgery, she is also a candidate for an ectopic pregnancy. Not only that, a patient who had a previous sterilization done, puerperal sterilization done, or laparoscopic or interval sterilization done, she might conceive by mistake when it rejoins the tube joints. Then also we can get an ectopic pregnancy. And some of the properties, not properties exactly, intrauterine contraceptive devices, the hormone devices especially, or the patient when they are having a contraceptive device introduced into the uterine cavity, hormonally impregnated ones, the patient can undergo an ectopic pregnancy. So also progesterone hormones, when they are on hormones, oral contraceptive hormonal, only progesterone only the patient is prone for ectopic pregnancy. Sometimes there are miscellaneous causes, like they say transmigration, wherein the fallopian tube is damaged on one side when the tube is removed because of previous surgery or anything, and then the ovum has to travel a long distance from one fallopian tube to the other. In that case, it's a transmigration, and is a longer route it takes to enter the other opposite contralateral fallopian tube. It takes a longer time. Because of that, we can get an ectopic pregnancy. These are some of the causes wherein it's because of the congenial nature of the fallopian tube, and the ectopic pregnancy occurs in the fallopian tube. And so the problem is there is a fatal problem for the patient who has an ectopic pregnancy, not only the fallopian tube and also to the ovum itself, because there's a small place, the embedding thing is not proper, because there is no decidual reaction. The decidual reaction wherein the fertilized ovum has to get buried, because of the trophoblastic infiltration. Because of that, it can erode into the tube and it can rupture into any of the vessels. The tube can rupture as such. A traumatic rupture of the fallopian tube can cause torrential hemorrhage as such. Plenty of blood loss into the peritoneal cavity as such. She may have an intraperitoneal hemorrhage, shock, and the patient can die. That is hemodynamically unstable ectopic, which occurs, is very fatal for the patients. Sometimes when it doesn't occur, it can, usually when it is near the infundibulum, nearer to the fallopian outer surface, in the trumpet-like surface, which I have told. Sometimes when it occurs there, it can just expel outside like a tubal abortion, wherein the result may not be that bad as the tubal rupture, and it is not that much bad for the patient also. That is, it can be just missed like any tubal or any normal uterine abortion like that. So patient can miss it, except for a small discomfort in the lower abdomen. So that is about the fate of the ovum, that's about the fate of the tube, and the patient can get admitted. And because of the various reasons of this, how it goes, it determines whether it is a tubal rupture or a tubal abortion. When it's nearer to the uterine cavity in the interstitial portion, sometimes the patient is lucky enough to get into the uterine cavity, sometimes it can get embedded. In that case, it can continue as a normal pregnancy also, but it rarely occurs. But when it ruptures in the interstitial, it is sometimes very dangerous, because even tubal, not only tubal rupture, it can be just like a rupture uterus itself, and the hemorrhage is too much torrential. That also can occur. Now let us see what are the signs and clinical features, signs and symptoms. The patient will definitely have a small short period of amenorrhea, wherein, and then afterwards it's an atypical amenorrhea. Sometimes depending upon the site, supposing this ischemic portion, very short period only she can have an amenorrhea. Before she could realize that she is pregnant, it can rupture, and the tubal rupture can occur. It can be a fatal disorder for the patient. Sometimes it is ampullary portion. It can grow up to 10 to 12 weeks like that, or if it is an infundibular portion, still more longer time. In the interstitial portion, sometimes the pregnancy can go up to 14 to 16 weeks also. It's very rare in that case. So now, considering the features, I already told it, the result as such, how it's going to, whether it's an abortion or a rupture, or it's going to continue as pregnancy, how much the patient is going to lose blood, it all depends upon the site and the fate of the fallopian tube or the fate of the ovum, how it is going to be. Now let us see, the initial patient will have a period of amenorrhea, typical amenorrhea is there, and spotting is there. Definitely, because of the spotting, the patient will definitely have the pain before bleeding. That is one of the symptoms. That is how we distinguish from a threatened abortion to an ectopic pregnancy. Not only that, sometimes other symptoms of pregnancy like breast signs, or sometimes even nausea and vomiting may be there, depending upon the beta-HCG secretion. You all know, because whenever there is a pregnancy, there is a urine test, pregnancy test positive. When you don't find, when the pregnancy test is positive and don't find a gestation sac inside the uterine cavity, we always suspect it is ectopic pregnancy. That means the sac is somewhere else. It's not in the uterus, and the urine test is pregnancy test is positive. So we always, whenever we don't find, when the beta-HCG level is 1500 international units, when you don't find a gestational sac, we always send it, see for the beta-HCG whether it is doubling up after 48 hours. If the gestation sac is not present in the uterus, then where is it? Whether it is in the fallopian tube. We have to see whether it's an ectopic pregnancy. So the investigations are urine pregnancy test, beta-HCG, ultrasound examination. Transvaginal ultrasound is fantastic. It has ruled out early gestational tubal pregnancy, and we are able to diagnose it within a jiffy, and that is really depends upon the beta-HCG. Even if it's a smaller, 1000 international units, transvaginal can usually pick up. Unlike the transabdominal ultrasound scan wherein we have to see, we are able to see a gestation sac only after 1500 international units of HCG. So number one, first patient should have a beta HCG. Yes.